Hi, I'm Jack Cush with Room Now. This is QD Clinic. QD Clinic is brought to you by Room Now Live. Room Now Live, we got a lot of great female speakers on our program. I'll tell you about those at the end. Today's case is actually about managing DMARDs in drug therapy during surgery. So I just got a call earlier today on a patient of mine, and it really doesn't matter the disease or the biologic. Let's say the patient is on either tocilizumab for Still's disease, etanercept for RA, abatacept for RA, anakinra for JIA, or even rituximab or infliximab. And yet they're going in for surgery. The question is, what is your instruction regarding holding therapies? Moreover, the patient's on a DMARD, methotrexate, hydroxychloroquine, leflunomide, sulfasalazine. So here are the rules. They're actually quite simple. They're based on evidence and fact and lies. So the evidence is very clear. Patients can actually continue their DMARD therapies throughout surgery, not stop them, and there's no reason to stop them. There are multiple studies showing that DMARD therapies, all the ones I just mentioned, can be continued throughout surgery without suspension. Now the problem is that orthopedists are not going to accept that. They are of the uniform belief that these drugs impair wound healing when in fact they don't. Wound healing is actually a function of a wound infection, and the question what's going to cause wound infection? Well, steroids first, and then other factors that are not related to you, the rheumatologist. But rather than get into a fight over the evidence and the facts, you have to lie. So it's okay to tell the patient and the surgeon to be off the DMARD for 2 weeks and to restart it 2 weeks later. Almost no one is going to flare unless the patient's poorly controlled, in which case you got to rethink your strategy. Now, what if the patient's on a biologic? Here there are rules, and the rules generally state that the patient should be off of the biologic for one dosing interval, meaning that they should be off of etanercept for 1 week or more, or an every 2 week medicine like tocilizumab or adalimumab for 2 weeks or more, or in the case of infliximab, be off of it for 6 weeks or more, and then have your surgery and then restart it 2 weeks later. You can just go with one simple rule. And a simple rule basically is states that you should be off the biologic for 2 weeks, have the surgery, restart it 2 weeks later when the sutures are out and there's no evidence of infection. Because what's driving this is, number one, you don't want to have surgery with peak drug levels of the biologic you are going to give. Secondly, you don't want to wash out the biologic totally, because washing out the biologic will cause a flare of activity, which will cause inflammation, and inflammation will drive infectious risk and post-op complications. So be off for 2 weeks, surgery, restart 2 weeks later when the sutures are out. It's the same as DMARDs. Have a uniform rule. It works for everybody. I think this has worked for me. You should tell me what your thoughts are. Room Now Live. Some of our speakers, Michelle Petrie talking on thrombotic risk in lupus, Alexis Ogdi talking about the epidemiology of psoriatic disease, Maureen McMahon talking about health disparities in lupus, Melody Young talking about comorbidities in psoriatic disease, and Maya Book talking about difficult RA. Those are just a few. It's a great program, roomnow.live. From home or from Fort Worth, you choose.